The incidence of type 1 in the elder age groups is also increasing. We just realized that from the ADA. So what is your, in practice in India also you are seeing that trend which they are seeing in the Western countries?
Absolutely. If you see many of the so-called type 2 diabetes who are lean and thin and not responding to oral anti-diabetic drugs, let's say after 6 months of treatment, they are absolutely uncontrolled. And then gradually they have a very high glucose profile, catabolic state, weight loss, polyuria, polydipsia, polyphagia, and when you measure their GAD antibody, they are present. So these are the type 1 diabetic patients who are developing type 1 diabetes after 30 years of age, and we label them as LADA, latent autoimmune diabetes of adult.
True. So is LADA where we diagnose as type 2 and then they progress to type 1, and double where you have type 1 and then develop features of, they are like two sides of the same coin,
yeah,
but
absolutely.
One comes first and the other comes differently. So in management principles, now you have a type 1 and we know that he's prone to microvascular.
Yeah.
Then you have the metabolic abnormalities and he's prone to macrovascular.
Yeah.
So as a clinician, we need to make sure we are prolonging life. Is there any, would you be adding a metformin and a statin earlier in these patients? And is the management different as such?
Yeah, that is very important aspect what you highlighted, that once you label them as double diabetes and they have insulin resistance and they have component of metabolic syndrome like hypertension, dyslipidemia, then of course their macrovascular complications are very high. And probably guidelines are not there, but probably we will be happy to start with statin therapy in them and very tight control of blood pressure also, in addition to very tight glycemic control with the help of basal bolus therapy. And as you rightly highlighted, some of them may respond to metformin in that scenario, and probably guidelines are not there, but DPP-4 inhibitors may be used, but at present we are looking at SGLT2, which may be of more usefulness in this type of patients in addition to GLP-1 receptor therapy.
Very true. They would have the metabolic syndrome, and SGLT2s would also help in reducing the insulin requirement.